Good evening. On behalf of Team Juventus, I, Alhad Mahajani, VP Marketing, accord each one of you a grand welcome to this webinar named Genitourinary Syndrome, Vulvovaginal Atrophy, and Vaginal Rejuvenation. At the outset, Juventus thanks Foxy, Amox, Indian Menopause Society for the association for this webinar. I also thank the organizing committee, Dr. Alpesh Gandhi, Dr. Anita Singh, Dr. Jay Tank, Dr. Nandita Palshetkar, Dr. Arun Nayak, Dr. Jignesh Shah, Dr. Anita Shah for giving us this opportunity. I also thank the moderators, Dr. Basav Mukherjee and Dr. Rajendra Nagarkatri for association, and also thank esteemed speakers for today's program, Dr. Ragini Agarwal, Dr. Shobhana Mohandas, Dr. Anju Soni, and Dr. Piki Saxena. Juventus always has been at the forefront of forging alliances with Foxy and its associations for scientific dissemination of information. Juventus, with your good wishes and support, has been able to provide with many first-time products in the field of gynecology like Atosiban, Tosiban, Ivanu tablets and gloves, Isrin and pelvic gel. We are pleased to be associated with Foxy Midlife Management Committee and present to you Dr. Rajendra Nagarkatti, Chairperson Foxy Midlife Committee. Dr. Rajendra Nagarkatti has been is a chairperson of Foxy Midlife Management Committee, chairperson of MOX Midlife Management Committee, executive council member MOX, past president of Association of Fellow Gynecologists, joint treasurer of Association of Medical Consultants Mumbai. He is also the past president of IMA Meera Bhayandar branch, past president of Bhayandar Medical Association. He is a consultant obstetrician and gynecologist par excellence at Ashirwad Maternity and General Hospital Bhayandar. He is associated with Wokhad Hospital Mira Road and Bhimsen Joshi Municipal General Hospital Bhayandar. I request Dr. Nagarkatti to carry on with the scientific proceedings for today's webinar. Thank you, sir.
Thank you, Alhad sir, for the kind words. And first of all, we wish to thank you and the team Juventus for organizing this wonderful webinar for Foxy, IMS and MOGS. This has been hosted essentially by the Foxy Midlife Management Committee. And we wish to thank our Honorable President, Dr. Alpesh Gandhi sir, President Foxy, Dr. Jaideep Tank, Secretary General Foxy, and Dr. Anita Singh, Madam, Vice President in charge of this committee for giving us this opportunity. We also wish to thank President of MOGS, Dr. Nandita Palshetkar, Madam, and Dr. Arun Nayak, Secretary General of Foxy, for having associated of MOGS for having associated MOGS with this program. And then we also wish to thank Dr. Jignesh Shah, President of IMS Indian Menopause Society, and Dr. Anita Shah, Secretary General of the Indian Menopause Society, for association of IMS with the program. This has been an association of Foxy Midlife Management Committee with IMS since last year, and we have been doing programs together. Well, we need to get on with the program, but before that, I would like to accord a warm welcome on behalf of Dr. Alpesh Gandhi sir. Dr. Alpesh Gandhi was supposed to be joining us and he was supposed to be giving the address himself, but he had a last minute, he just called me some time back saying that he has an emergency eclampsia patient and he is busy with that patient. So he has asked me to read out his message, which I will do so. But I have requested him, if possible, he may join in once the patient has settled down. So I'm reading out his message. Dear friends, on behalf of the Foxy team, I, Dr. Alpesh Gandhi, welcome you all as President Foxy to this wonderful webinar on a different topic, vulvovaginal atrophy and genitourinary syndrome. Foxy has been in the forefront of academic and social activities even during this COVID pandemic, and we will continue to do so. The Foxy Midlife Management Committee, along with its chairperson, Dr. Rajendra Nagarkatti, has been doing excellent work, doing so many webinars on different topics, and I congratulate him for the same, and hope he continues to do his continue to do excellent work for Foxy, and I wish him the best. He also wanted to talk about the 1st July Doctors Day program, and he wants you all to have an active part in this particular program. There is basically it's on organ donation. We have sent messages in all the different Foxy groups, and to you individually also. We will be sending messages as much as possible. Try to motivate people from your area to sign or pledge themselves for organ donation. You may take a picture of the person taking the pledge, and also a picture of your society with the particular person, and upload it. It has to be uploaded before the 29th of June. There is also an ongoing competition for the best poster and the best skit. So we request all the Foxians to participate in this latest activity of Foxy, which is towards the social cause of organ donation, because a person can donate almost different parts of his body, which can save the lives of 8 different people in one shot. So that would be a very, 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 as they say, it's this kind of a dan is a sarva shrestha dan. So we should encourage this, and we should be with our organization in this endeavor. So with these words, I will now move on to the next part of the program, and that is that there is a video by the EMOGS Association and Dr. Nandita Pashetkar, madam. She has a message for Manyata, which is basically to upgrade your skills and that of your hospital, of your staff, so as to give the best of care. So basically it's giving quality care to your patients, and for that we have a video. So I request Srimon from Science Integra to please play the video of Dr. Nandita Pashetkar.
Hello everyone, I'm Dr. Nandita Pashetkar. I'm a gynecologist, the immediate past president of Foxy and the current president of EMOGS. I'm here today to speak to you about something that's absolutely crucial to the work that you and I do as doctors, that is quality of care. We are all trying in our own ways to navigate the threats that COVID-19 poses to pregnant women and their newborn, and how we can safeguard them against these threats. At this time, perhaps the most important and responsible thing we can do for our patients is to ensure that we maintain, even improve the quality of care that we offer them. We can achieve this by ensuring that our healthcare teams are well equipped with information and practical knowledge to deal with the emergencies, at the same time following the safety protocols. But how can we ensure such preparedness for our healthcare staff? In this regard, I would like to introduce you the Lakshya Manyata program, an initiative which I am closely involved with and can personally vouch for. A collaboration between Public Health Department, Government of Maharashtra and Foxy, Lakshya Manyata is Maharashtra's certification initiative which aims at improving the quality of maternal and newborn care services in private facilities. By providing hands-on and online trainings on clinical and facility protocols, the program equips and strengthens your healthcare staff to provide a safe and respectful childbirth experience to every woman. To make this initiative more relevant and help you navigate through these challenging times, we are in fact offering special interactive sessions on pregnancy care and COVID-19. Let me share a host of benefits the program offers. It aligns with the WHO and national quality standards. Be sure you're updated with verified guidelines also. It builds confident, efficient, and capable teams. provides protection against medical legal cases. You have Foxy's support. Gives you a competitive advantage over non-certified peers and ensures peer recognition. The state government recognizes your facility offering excellence in maternity services with quality care. Helps prepare private providers to apply for accreditation such as NABH or an eligibility requirement for reimbursement from many insurance schemes. Provides greater access to knowledge and tools to a network of quality certified providers. You can get access to all this and more at a low cost, much less than the other certifications. So far, over 150 facilities have already registered in the state and 3 have been certified, and many much more are in the process of getting certified. So please register for the program today at www.maharashtra.lakshamanyata.org and become a part of the quality care movement. If you have any questions, don't hesitate to reach out to me. I'd be happy to address them or connect you to someone from the Lakshya Manyata team. I'd also request you to spread the word in your circles. Let's together ensure safe motherhood in Maharashtra. Thank you, everyone. Be safe and be well.
Yeah, that was Dr. Nandita Palshetkar, immediate past president Foxy and currently president EMOGS. Thank you for the message, madam, on Lakshya Manyata. We now move on to the program. So it's my proud privilege to introduce to you my co-moderator for today's program, Dr. Basav Mukherjee. Can I have this? Dr. Basav Mukherjee is an MD, FRCOG, FICOG. He's done his basic medical schooling from the prestigious CMC Vellore. He's a FIGO coordinator for South Asia on Safe Abortion Committee. He's a clinical examiner for RCOG exams in India. He's a member of the Governing Council of ICOG from 2015 till date. He is an honorary secretary of the Bengal Obstetrics and Gynecological Society. He is Young the One Gynecologist Award of AOFOG at Taipei in the year 2011. He is a past chairperson of the Family Welfare Committee of Foxy 2013 to 15, and he is a vice president elect Foxy 2021-22. He was also the organizing. He's also the organizing secretary of the AICOG 2022. So I welcome Dr. Basav Mukherjee. Moving on, we have the first of the speakers. I think I will request Dr. Basav to introduce the first speaker. Basav?
Yeah, thank you, Raju. It is my pleasure to introduce Dr. Shobana Mohandas. Dr. Shobana is the Vice President of the Indian Menopause Society. She is the past Secretary General of the Website Committee and the past Website Committee Chair and the Quiz Chair of the Indian Menopause Society. She has been a member of the Foxy Food and Drug Committee in 2018-19 and a member of the Foxy Endocrinology Committee between 2014 and 17. She also has been the South Zone Coordinator for Foxy Hysteroscopy Workshops in 2011, the Vice President of IMA Thrissur during the term 2016 to 17, President of IMA Women's Wing 2012 to 2016, Free Paper Committee in charge on AICOG 2006 at Kochi, the past Scientific Committee Chair, Journal Editor of TOGS, author of 2 textbooks in gynecology, and invited speaker at more than 120 venues. Dr. Shobana, I'm sure there are a lot of people waiting to hear you, and you're on, Dr. Shobana.
Thank you, Basav, for the nice introduction. We have been friends for a long time now. So now we'll just get on with my slides presentation. We keep meeting at all venues, me and Dr. Basav. So, sorry.
Is it the other one?
I think this is one, sorry. Yeah, it's the same one.
Same one.
But the title, and I have not changed the title. That is Euro. 1 minute. The urogynecological problems in gynecology was the topic given to me. Sorry, I have to change this. 1 minute. Yeah, this is the one. Can you see my slides now?
No,
Yes, yes.
you need to share it. You need to put it on slideshow.
Yes, can you see it now?
We can see only one slide, but we can't unless.
Yeah, I will change it. No?
Yeah.
You can see it now? Okay?
Yes, yes. We can see the first slide. Yes.
Yeah. So menopausal women can have a lot of problems. Like I thank Dr. Nagarkatti and Dr. Basap for giving me this opportunity to share stage with my dear friends and all of you, new friends and old friends. So it's a good fun. So let's get on with this. Now I'm being given 12 minutes, right, Basap?
Yeah.
So I will stop at 12 or 13, whatever. Okay.
But you have your slide. Say what we want to hear from you.
Okay. So urinary incontinence, dry vagina, atrophic vaginitis, urinary incontinence, and prolapse. These are the things that a woman will face in a menopause. Why is she facing it? Because there are estrogen receptors in the bladder. Not only that, vagina, uterosacral ligaments, levator, and you name it, everywhere estrogen is there. And before menopause, a woman vagina will look like that, and after menopause, it will look like this. And estrogen causes better propensity in epithelium, not only in the vagina, and better vascularization, even in the bladder also it is there. That's why you get UTIs increased and you have atrophic vaginitis in menopause. So let's take the bladder part first. A girl can hold urine because she doesn't like the school toilet. An adolescent doesn't like to wear a jeans sometimes because she's incontinent. An old lady has to go and wear a panty liner or whatever. And Indian ladies have to be looking first whether there is a bathroom in the place where they have to go. Then only you can take your grandmothers there. A hall with a bathroom, you can take a grandmother, otherwise she has to stay at home. So everywhere they are bathroom centric after menopause. So now, a study actually was done. They claim they have studied 1,500 women for 6 years. Can anybody in India do this? I don't know. But they say they have done it, and they studied urinary incontinence. And they found that there is no significant increase in SUI, but there is an increase in urge. And even if there is a little increase in SUI, if at all, that is because of obesity, not because of menopause, according to them. So there was another EPIC study. There they studied men and women above 39, above 60, below 39. And the rise is more in after 60. Women also, it's almost the same. So they found that it's not just estrogen. You know, when a man goes to the airport also, he finds a problem. A woman is happy because their dress is such that they don't mind it. But the point is, overactive bladder is because of lesions seen on MRI, not just because of estrogen. So you just say you're old and you are incontinent, so live with it. You can't do that. You have to get out of your comfort zone, then only you can find success, and you have to face difficulties and solve them. So how do you solve these problems? One is stress incontinence or urge incontinence. You have to control weight loss. You have to cause weight loss if necessary. Fluid management is important. In conservative treatment for stress incontinence, constipation and cough has to be treated. Where in urge, you have to give time voiding and bladder training. Something like pseudoephedrine on all those drugs, imipramine and all, help in stress incontinence, whereas urgent incontinence, lot of other drugs are there. And then you have surgical. I'm not going to go too much into it because everybody is talking of those tapes and things like that. And intravesical Botox and percutaneous nerve stimulation, all that I think Dr. Anju Soni will be talking about. But what I will be giving is a overview of all the drugs. In my practice, I give oxybutyrin. I'm practically happy with that, 5 milligram, 1 or 2, 3 times a day. But severe urge incontinence, sometimes I am forced to add proxium to that. But the problem is when you give 2 drugs together, they will come with retention, and then you will have to give some, you have to stop one drug or something like that. That is there. Or you may stop that if they've got too much of side effects and start them on radifenacin or solifenacin. New drug on the market is mirabegron. Little costly, but it acts after 2 weeks. That is also there, but that's a new drug. So you have a whole lot of drugs you can experiment. So you have to explain to the patient, please don't run away from me. There is a whole lot of drugs. If one doesn't work, something else will work. So you please hold on, and we'll try one after another to see what works for you. So that's how things are, Types of incontinence, stress and urge we keep talking about, but we keep forgetting there is something called overflow incontinence and neurogenic incontinence in old ladies. You have to look for all that also. So this is one case which I want to present in an obese 50-year-old lady who had an hysterectomy 10 years back. She has got pain in left abdomen. She is dribbling urine on changing position. So why is she doing that? There's a 3 centimeter ovarian system. You keep wondering if it's a twist in that, And there is presence of residual urine in the bladder. So when she's got pain, I just gave her, and she is very obese, with distended abdomen. You can't put a scope inside, you can't open her, nothing. She has no stress incontinence on examination. So what is this problem? He has been to many urologists. Okay? Anju is calling me. I don't know.
Ma'am, actually, we are unable to see the other slides. We are just on the first slide.
Oh, you're not able to see this?
No, we need a slideshow for you. I thought that you were still speaking on things. We need a slideshow. Can you put on the slideshow?
It is on slideshow now.
No, it's not coming. It's not showing on slideshow. We're just seeing your second slide of your presentation stuck there.
Okay, now is it correct?
No, it's not correct yet. You need to put it on slideshow.
I put it on slideshow, but it's not coming here.
No, it's not showing in the. We can't see the slideshow.
It's on slideshow in my screen, but
no, that's minimized. The one lower down, the lower down button is the slideshow, no? The one which
you have to go to slide share. There's a green button at the bottom.
Slide share. She would have gone. Otherwise, we wouldn't have seen this. We would not have been seeing this.
Okay.
Dr. Rajendra, we would have been.
Okay. Okay.
That is, she's started something. But
on the right down. So
right down next to slide sorter would be the slide share.
Now, is it okay?
No.
Right down.
Slideshow.
Now you are screen sharing live. That's what they've shown.
No,
Yeah, we can see the screen, ma'am. We just need to select slideshow. It's
okay. Now is it okay?
Yeah, okay.
Yeah.
Can you change
See the pictures coming?
Yes.
Yes.
You're on.
Okay. This is the lady that I was talking about.
Okay.
Is it right?
Okay.
Yes.
Okay, so now she has been to many urologists before. Anyway, there's nothing much to watch on the screen and that. Okay, she was treated with antibiotics and trigger point injection, so her pain went off. Now I have to send her to the urologist, okay? And urology gave her high doses of methanacol to stimulator, that was like, and then she started passing urine and she was relieved of incontinence after 4 or 5 months. So you have to diagnose overactive bladder to know what to do. That is there. And it was overflow incontinence. Another patient came, she was she came with a 15 centimeter ovarian cyst, She went into bronchospasm. She had to be given hydrocortisone and post laparoscopic salping. Oh God. No, this is different presentation that has come. It's okay now. I'll go with this presentation. I'm sorry. Okay. This is another slide. This is another presentation. Shall I just finish off this presentation? Anyway, this patient also had retention of urine and there were no adhesions near the bladder. The retention was relieved on 50 milligram BD dose of methanacol. Suppose a patient comes with SUI, what will you do? I'm not talking about TOG, but if she wants to wait for the surgery, what will you do? Can you give any short-term measures? One thing that I would give is tampons. They work very well. They are available in most supermarkets. Until she waits for the surgery, it will stop SUI. So that's some practical tip I wanted to give to everybody here, that before she is waiting, at least, if it's SUI is only mild, you can do this trick. Oh Lord. So sorry, this is another presentation now.
You can close it, Dr. Shobana. You can open the one which you want to show us. The one lower one, would that be the one?
Yeah, this is. I will take the other presentation because yesterday I was asked to remove some slides and then there was a little problem. I had to redo my slides.
It's okay.
Okay, this is a patient I wanted to talk about who was on psychotropic drugs and the urine routine was normal. But the clap is for the fact that, can you see that?
No, ma'am.
No.
You share the screen again, ma'am, please.
The lower green button of share screen.
Ma'am, minimize your presentation and then come to Zoom link, the Zoom window, and select the share screen.
I can see only one Prashant here now.
Ma'am, come to the Zoom platform.
First you use your cursor and come down. Use your cursor and come down to the lower part of
I can see Basab Mukherjee on the side. I can't see anything else. One minute, can I just call my son?
Yeah, sure.
Ma'am, we have Prashant as our technical person. Prashant, can you please guide, ma'am?
I can see the Zoom thing here.
No, Zoom.
Yeah. Just make it full screen. Make it Zoom full screen.
When I click on it, nothing is coming. That's the main problem now.
No, you don't click. You just take the cursor down.
I took it down. It's not coming.
No, you can.
I can see BC Basab here on the side.
No, that's on the side, but the lower part is.
Lower one is not coming now.
Okay, but like you need to just
make it full screen. Make it full screen.
That's what I'm trying. When I click, it's not coming. When I click on Prashant, also I can't see anything.
No, Prashant, you don't click, Dr. Shobana.
Okay, now it's come. Okay, fine.
Share screen?
Yeah.
Yeah.
Yes, ma'am.
Sorry.
Perfect. Yes. Make it presentation mode.
Slideshow mode, no?
Yeah, yes, ma'am.
See, you can do it yourself.
I can. This confusion happened because I had to cut a few slides yesterday. So I put both the presentations there. Anyway, let's go get on.
Ma'am, can you please speak it?
Can you see this now?
Yes, ma'am.
We're good.
Okay. This is a psychotic patient who has the uterus in situ and claps up for that, The urine routine is normal. Again, I had given Betanacol. So I just want to highlight the importance of Betanacol in overflow incontinence. Besides all these big things, transient incontinence can also happen because of UTI, atrophic vaginitis, fecal impaction. We have seen that movie Piku, where all the old ladies have got constipation. All these people will have transient incontinence. Reduced mobility, old ladies will have psychological factors. They are worried about their children or grandchildren, cognitive impairment, diabetes, delirium. Everything can cause transient incontinence. It's not just overflow incontinence or urge incontinence. So also you have to see if there are antihypertensives that can cause decreased urethral tone. They can be on captopril that can cause cough and cause stress incontinence. Captopril causing cough. Have you ever heard of it? Verapamil and nifedipine can cause constipation or nocturnal, edema. That can cause polyuria and that can cause incontinence. So diuretics are the first line of treatment for hypertension, can also cause incontinence. So you cannot just talk about tape. You also have to take the BP of the patient, take a history, take a list of drugs she's taking, and then you go and treat. There are common drugs like sedatives, hypnotics, antipsychotics, common drugs like H2 receptor antagonists, SSRIs, gabapentin, NSAIDs even. All this can cause problems which can cause incontinence, can contribute to incontinence. this is the slide which I told you about the tampon. Now, I would like to discuss this lady who was a relative of mine who has undergone menopause at 42 years. She comes with burning in the vulva, pain during menstruation, urine shows pus cells. So it is a combination of UTI and atrophic vaginitis. And I gave her estriol cream once daily for 1 week and then twice daily for 6 months. She disappeared. And she was continuing for 1 year because the minute she stops the cream, she gets all the symptoms and she can't stop it. And after some time, she got breast pain. She didn't call me. She went to the surgeon. She underwent a mammography and a lot of mental trauma, thinking it's all breast, something wrong with the breast. And now she comes back to me and I said, all that cream must have caused the breast, tenderness. And before undergoing she should undergo a mammography. I'm not saying no, but she should not have undergone the mental trauma, thinking she's got breast cancer. She should have understood that the Evelon cream can also cause breast symptoms. But now, do you think I should stop the estrogen cream 1 year? So I said, oh, come on, you're having so many problems, you stop it. And she calls me up in a conference and she said, I'm bleeding profusely, do something. I said, what can I do now sitting here? How can she bleed profusely? After coming back from the conference and I see she's just bleeding from the red spots, almost like, withdrawal bleeding from a vaginal atrophic spots. You never hear of it, all this in the books, but you see it in practice. And the endometrium is thin on USC. All of you will, first thing they will catch me and no, she must have got concomitant endometrial cancer. No, she had a thin endometrium. And in fact, she stopped bleeding after some days. So now she can't stop the cream. And that is where some cream like pelvic gel or isorin gel or something that Juventus has, something like that I had on my table. On that, I gave it to her. I said, come on, you try it. This is how you try on things that you don't know. And actually it worked. And then now we are going and giving talks on hyaluronic acid is good for it. And there are studies on it. This happened in 2008, 2008 or something. It was not very fashionable in those days, but it did work for her. And then now, but of course, now you stop the estrogen cream. Bladder mein you can't give hyaluronic acid. No. So then again, she started getting back with the pus cells and now she with the urologist. I said, my side is clear, now you go off. So that's the use of, all the alternative drugs that can happen when estrogen is giving you a problem. See, when you have the patient is saying, I've got a lot of wind, so frustration, you sometimes give her a kite and say, you go take the fire kite with all your wind. But when she comes with recurrent UTI, you can't tell her go fly a kite. There, sometimes you have to have some other ways of treating it. And one is to give any of these drugs daily for 1 month. That is something which we were not doing when we were undergraduates. And there's also something which says you're supposed to give post-coital prophylaxis. A big coitus where you will have in these ladies with difficult, where hyaluronic acid has to be used. You have to use estrogen, I don't know. But this is actually from a geriatric journal I've taken this. And in my practice, I had been given Manos 1 gram BD is a research dose for recurrent UTI. Now they have this combination drugs, Manos, everything they'll mix up and they'll give a tablet. I don't know whether that will work. In my patients, I give local estrogen creams. Manos in that high dose research dose is now available only on Amazon. I kept and searched for it. That is how it is. But that used to work for me in my early practice days. Nowadays, it's not available in that dose. That company, I don't know, is not keep seeing me or not. So now that's the final part of my presentation. I'm sorry I overshot my time by 5 minutes. I'm sorry extremely. If a woman comes with 3rd degree prolapse, will you make sure she has no stress incontinence? You have to do a check and make sure that, you push the uterus inside and make sure that she has no stress. Otherwise, after the surgery, she will have a recurrence or she will develop SUI, which was not there because of the prolapse. That's 1 point for prolapse. Second point, prolapse in an 80-year-old, I'm sure all of us have to face. All this laparoscopy, I'm also a laparoscopy person, but my anesthetist is not going to give me a head down for an 80-year-old. They will say that you do what you want, but I'll give you a spinal, you do what you want. We all know, all of us don't have the luxury of anesthetists who are giving us this head low position. And many of them have comorbidities, most of them. So one thing is, hysterectomy is so simple to do, I felt, button-like uterus. And I used to do sacrospinous colpopexy. One day, once I thought there is a uterus. She told me I've had a myomectomy, and actually she was saying it was not what she called myomectomy, was actually the hysterectomy. And on table I found a vulva. There is no uterus, and I did sacrospinous colpopexy. But after 2 or 3 cases, I'm telling you one case, in spite of this sacrospinous colpopexy, that lady had constipation and she pushed and pushed, and the prolapse recurred at least partly. The wall started coming down at least partly. This is a reality. And I'm wondering if I should start learning leaf force operation, because now as I grow older, I'm getting wiser. And maybe, sacrospinous is not so simple when they have constipation. And your ligaments are lax, so you can't do high uterosacral ligation anyway. And laparoscopic, all those, meshes and all to put in a morbid patient, I don't know. So this is a thought for all of you. And I hope that somebody will discuss on this topic also. Thank you so much. And I'm extremely sorry for mixing up the 2 presentations in my computer. Thank you so much.
Thank you, Dr. Shobana. Dr. Rajendra, should we move on to the next talk?
Yes. Yeah, I think so. Yeah. The next speaker is Dr. Anju Soni. Can we have the slide of her CV? Yes. Dr. Anju Soni is her special interest subjects are high risk pregnancy, critical care, gynae, minimal invasive surgery, urogynecology, menopause, yoga. She's a very, very active person, a good friend from Jaipur. She's currently the chairperson of the HIV and AIDS Committee 2020 to 22. She is the president of the Jaipur Obstetrics and Gynecological Society 2018-19, current president of the Jaipur Menopause Society 2017-18, committee chairperson of public awareness of the Indian Menopause Society, vice president of JOGS 2013 to 15, secretary of IMS Jaipur chapter 2015-17, a patron of the AGESR. She is also a member of the International Menopause Society, a patron of the PCOS Society of India, a North Zone coordinator for FOXY, committee member for FOXY endoscopy, and a TOT prescription writing MHT, Adbhut Matutva and HIV/AIDS. So it's over to you, Dr. Anju Soni, madam. She will be speaking on a very different topic, something called as the painful bladder syndrome. Please listen to her. This is a different topic, and I think we should get some new insight into this. Over to you, Dr. Anju.
Thank you, Dr. Rajendra. Can I share my screen?
Yes. Please.
No, not yet.
Dr. Anju,
yeah.
All yours.
Good evening, Dr. Ragni, Dr. Rajendra, Dr. Basav. At the offset, I would like to thank all of FOXY especially, and everyone who have, given me this occasion of talking on this topic, which is a very, very different topic. And most of the time, patients come to us, but what happens is that they normally are shunted away from us, and we don't see them and send them to you, and the patient is shuttling between a gynecologist and a urologist. So this condition we'll talk a little about. I had a girl who had a severe bladder and pelvic pain since the age of 15 years. She went from a doctor to doctor, and finally after 10 years, she came to our hospital, and I discussed with my team of urology, and we agreed to do a exploratory surgery on her. And what we found was really shocking. The girl had perforated bladder due to a bad accident at home. and 10 years ago, and her bladder was irreparable and had to be removed. And she is doing very well now. Now, when we come, this subject is very, very not taken very well with everyone, because even in all over the world, there is not even a consensus about the nomenclature. Interstitial, some places it is called, other people call it painful bladder syndrome, and in Japan, Malaysia, they call it bladder pain syndrome. They in this China, they call it hypertensive bladder syndrome. So there is no consensus in this nomenclature of this subject, though it is a debilitating condition. But still, we do not know much about it. It's been seen that it's been there in the Western country, but we now know that it is there in our country also. Now, when I go through the presentation, I'll be talking little about the definition, epidemiology and etiology, diagnosis, and then evidence-based medicine. Now, painful bladder syndrome, as per International Continence Society, has been a suprapubic pain related with bladder filling accompanied by increased frequency in absence of proven urinary infection or other obvious pathology. It is reserved for the patients with characteristic cystoscopic and histological features of this condition. Now, when we come to AUA guidelines, they put more importance on the unpleasant sensation, which is pain, pressure, or discomfort perceived to be related to urinary bladder, associated with lower urinary tract symptoms, and it has to be more than 6 weeks duration, and definitely in the absence of infection or other identifiable causes. Now, when we come to the guidelines made by us, we have put more stress on the symptoms as compared to the cystoscopy and other findings. And in that context, it is defined as a pelvic pain or discomfort, which means pressure or throbbing for at least 4 to 6 weeks duration, and which increases with bladder filling or decreases with micturition in absence of definable pathology associated with urinary frequency or urgency. Now, we all know that we as gynecologists cannot take a scapegoat by saying that we don't know about this condition. We have to know about this condition because the patient first comes to us. It is a very debilitating condition which has a remitting issues. It impairs the quality of life in a big way. The etiology is still an enigma, and there are still no effective therapies, and it's a huge economic burden for any country. Now, it's a urological mystery. We don't know. Some people feel whether a patient is psychotic or having some problem. And since, as we have just shared, that there's no standard terminology, there's definitely a lack of uniform definition also, and also validated diagnostic markers. And of course, the etiology and pathophysiology both are not known. So basically, it is a diagnosis of exclusion. Coming to the etiology, epidemiology, it has a considerable variety among different studies and different countries. The first study, which was done by Helsinki in 1975, showed that it's more common in women as compared to males, and the incidence was 18.1 per lakh women. Now, when more recent studies and researches were done, it is seen that the prevalence is much, much higher, as said. And in US, this is a data which was updated in 2018. It shows that it is from 2.5 to 6.5%, which depends on the diagnosis by patient, and other is the increased number is because of the questionnaire answered by the patient itself. In India, though there were not many studies and researches, but what I found from data in 2015 said that it has a incidence of 100 per lakh women, and about 1.5 to 1.25 million patients are there in the country. Now, coming to etiology, it is a very multifactorial causes, and there are, of course, many theories which are related to the etiology of this disease. We know that could be because of activated mast cell diffuser muscle, an autoimmune disorder. It could be a neurogenic factor, could be a toxic substance in the urine, could be infections, and could be deficiency of glycosamine glycan. Now, when we come to the infection, there is very little data to support the role of infectious etiology. The bacterial cystitis may be the first step leading to low level of inflammatory responses, and this is unlikely to that active infection is involved in ongoing pathological process or that antibiotics have any role in the treatment. Now, coming to immune or neuroimmune mechanism, there is definitely a role of this mechanism. There is excessive release of sensory nerve neurotransmitters and mast cell inflammatory mediators, which lead to propagation of the symptoms. On the other hand, the inflammation which occurs leads to altered nerve growth factor, which causes morphological changes in the sensory and motor neurons, which further leads to long-term symptoms and even after the inflammation subsides. Now, we definitely know that there is some role of mast cells which release histamine in the tissue, which causes the pain, hyperemia, and fibrosis. There are a high number of activated mast cells seen on the bladder biopsies, and this could also contribute to failure or epithelialization of bladder surface following injury by two potential mechanisms. That is inhibition of epithelial cell replication and interference with epithelial cell spreading, thus resulting in leaky epithelium found in some of the cases. Now, leaky epithelium, we all know that we have a gag in the bladder. There is a gag layer which functions as a permeability anti-adherence barrier. The patient with IC have a lower excretion of urinary uric acid and the gag than normal, and possibly this due to leaky transit epithelium that might also be absorbing this substance and leading to increased mucous permeability and non-specific and consequences of bladder inflammation. We can see this in this picture clearly that there is an irritating solution and deficiency of gag layer which is damaging the urothelium, causing inflammation and irritation of nerves. Further, there is definitely a role of neurogenic inflammation also. Because of the activation of sensory nerves leading to neuropeptidase as substance P or neurokinase, and this would lead to neurogenic inflammation. So when we look at this program, the ultimate result is that there is a bladder insert, and that lead to the epithelial layer damage, potassium leak, activation of C fiber, mast cell, and more injury, and it goes on. And this also shows the similar thing, showing in a diagrammatic manner that how there is leaking and this potassium cells in urine damage the epithelial cells and lead to the nervous. Now, in this picture, we can clearly see that in the bladder, there is a normal protective bladder lining, and in the beginning, there is a thinning of the protective layer, and then there is the pinpoint bleeding in the agglomerations, and then the typical humoral lesions, which are known to be the part of this irritable, painful bladder syndrome. There is definitely a nervous system and interstitial problems, wherein there is repetitious activities of C fibers, resulting in progressive buildup of magnitude of electrical responses recorded in second order dorsal horn neurons, and this phenomena is known as Wendup phenomena. And there is persistent NMDA receptor activation causing spinal cord cells to undergo tropic changes, and pain resulting from subsequent stimulation becomes exaggerated and prolonged. Now, coming to diagnosis, we all know that the diagnostic approaches vary widely. There is no standardized procedure of diagnosis. There is no general agreement on any diagnostic algorithm, and there is heavy reliance on other aspects of NIDT criteria. This NIDT criteria is basically based on census among a group of researchers who wanted to define a strict homogeneous criteria for the research. And it was not meant to be. So, but rather it was to ensure the compatibility of the groups who are doing the research. So, but there are a lot of criticism for this criteria because most recent studies show that all the cystoscopic patients may not have the diagnosis present, which is shared in them, and then most of the patients from 40 to 60% have minimal reduction in capacity, and about 9% have had normal cystoscopy, and glabellulations are not specific for eyes. IC and may not be just a response to retention after a prolonged period of underfilling rather than pathological process. Patients with symptoms for more than 9 months was only positive considered, which is not there. We can have a patient less than 18 months also. So this is also another criticism. Another criticism was that there was many other symptoms which were together problematic, and fully 90% of the clinicians agreed that patient diagnosed with IC by those criteria indeed may not have the disorder, and 60% deemed to have IC, and these experiences would not have made the. So coming to the pathology, it is very, very important to exclude other diagnosis. There is no pathognomic picture, no consistent finding which can say that this patient is a patient of peripheral bladder syndrome. Of course, there is a great variation with the same patient's pathologic findings at different timings. But when we come to comparing, can we do a KCL test to diagnose it? Comparing the sensory nerve provocative ability of sodium using 0.4 ml of KCL solution, this will provoke pain and provocation of symptom constitute the positive test, but it is not considered valid by many groups, and it has a false positivity in 36 patients of the asymptomatic patients. It is also seen that up to 25% of patients meeting with an NIDTK criteria will have a negative test. And it may be positive in other cases like radiation cystitis, UTI, and overactive bladder syndrome. So how do we make the diagnosis? There are 3 consensus panels that concluded the diagnosis is suspected on the basis of a detailed history, physical examination, laboratory test, including the negative urine analysis, negative urine culture, negative cytology, and of course possible cystoscopic findings. Now there is this marker which is known as anti-proliferative factor. It is found out by Key's analysis. They said that it is a peptide growth inhibitor which is produced by urothelium of a patient of interstitial cystitis, and it is found in the bladder urine, not in the renal pelvic. And high APF has been linked to patients with many racial backgrounds, and the sensitivity and specificity is as high as 94 to 95%. It could be used to gauge the response of treatment also in improvement of activity noted after hydrotension and neuromodulation. APF seems to have a role in increasing cell permeability, induces a reversible inhibition of HbAPF production and normal bladder epithelium proliferation. And when we talk of the pathologic features, we just said that though they don't have a specific features, but what was found that a patient who comes with nighttime frequency may have a complete loss of urothelium and has increased mast cell counts in the lamina propria, along with increased granulation tissue and increased vascular density. The urinary urgency was seen in a patient who had submucal granulation tissue, and also urinary pain was seen where the mucosa of the urothelium was denuded, and plus there were lots of submucosal hemorrhages. Now, clinical presentation, we all know, can be urinary frequency, urgency, and pains, and incomplete bladder emptying, a constant cessation of a compulsion to void, dyspareunia, sex distress, declined libido, and orgasm frequency, and also sense of pressure or discomfort. These are some of the tips which were given by Indian data. They said that patient should have a discomfort in lower abdomen with frequency, urgency, discomfort increases with bladder filling and decreases with emptying. Once the patient gets desire to void, it cannot be postponed. No other pathology, anal symptoms with urinary symptoms, and no anal pathology was seen. Patient gets a desire to void and has to go for micturition immediately. So these are some unusual symptoms in the order of percentage from incomplete evacuation to difficulty of urinary. Because of shortage of time, I'm not going to details. Then there are some unusual non-urinary symptoms also when patient comes from anal discomfort, difficulty in sitting, walking, and pain at ejaculation in cases of males. And also, some patient may have other associated bowel syndromes like acidity, gas, muscle joint pain, stiffness of lower back, fatigue not relieved by rest, abdominal pain, etc. So, when the patient comes to us, we have to find out the index of painful bladder syndrome, interstitiality. So, we take a detailed history. How often have you felt the strong need to urinate with little or no warning? Mind you, it is very important that all these patients, when they come to you, they do not have any kind of incontinence. They just have an urgency and frequency. How many times you have urinated? So it's better to make a diary, bladder diary for 3 days, which will really guide you what kind of patient symptom has and how many times patient has an actinuria, and whether there is any pain or burning in the bladder. Now, there are some potential risk factors like hysterectomy, allergy to some drugs and foods, recurrent sinusitis, URI, arthritis, that means immunological element, irritable bowel syndrome, frequent stool spastic colon, family history, cancer of vagina, cervix, kidney, bladder, urethra, hypo or hyperthyroid, and also trigonitis and urethral stones. Now, detailed history, we have to tell them to fill a questionnaire. There are 3 types of questionnaires which I have not mentioned because of the time restraint. There are history of risk factors and diet and food, caffeinated and consumption of caffeinated foods and alcohol, renal rectal disease, and also association of depression, sexual dysfunction, abuse, emotional, physical abuse or neglect, chronic constipation, and other inflammatory condition. We have to do a detailed pelvic examination of full bladder, palpation of urethra, bladder base, bimanual examination to look for any adduction masses, and we have to look for assessment of rectal or pelvic floor levator muscle to look for the bone. And when we look for this, we find out that there could be spastic or tender areas of old scars, which is a big stressor for this disease. The pain or bladder filling that reproduces patient symptom is very suggestive of ICA. We, as just said, that examination is very essential, and we have to see for hernia, masses, and everything. Now, the inclusion criteria for ICs are that patient may have, if a patient has Horner's ulcer, pain or bladder filling relieved by emptying, pain in suprapelvic, pelvic, urethral, or perineal region, glomerulation on cystoscopy, decreased bladder compliance on cystogram. 2 of these factors, if are present, they are the positive for IC. Then what are the exclusion criteria? A girl less than 18 years of age, duration of symptoms less than 6 weeks, micturition frequency less than 8 times daily, less than 2 times in the night, and also presence of UTI, stones, or other conditions. So all these things, they really reduce the quality of life in a woman by causing pain, urinary urgency, and frequency. Patient is deprived of sleep, curtails her activity, sexual intimacies definitely limited, and the reduced ability to go to work. All this give rise to lots and lots of problems to a patient. Now, when we come to investigation, we have to rule out the problems by doing a routine urine culture. And in our country, the most common thing we do is an ultrasound, wherein we measure the post-voyage urine. And second most common investigation which we do is cystoscopy, urodynamics, and bladder biopsy. I'll come in next slides. Negative test result do not necessarily mean that patient does not have these things. So when we do a cystoscopy, we see glomerulation, and when we fill the bladder, we see this, and then we sometimes we see red mucosal patches and vessels radiating from a central pale scar. Then we empty the bladder, refill the bladder again. We'll see those hemorrhages, petechial hemorrhages coming, which may not be seen on first filling. Now, bladder biopsy should always be performed if the patient's symptoms do not respond to first-line treatment, and minimum 3 samples should be taken, and a normal biopsy may be found in in some patients who do not have venous lesion, it is very, very important to exclude the other causes, especially in India. The most common thing is the tuberculosis of urinary bladder. That is why in India people thought that this is a disease of a Western world, not India. And this is a typical ulcer biopsy taken, which shows that there is a lot of lymphoid infiltration in the lamina propria, and there is interstitial cystitis. Urodynamic studies.
Wind up. Dr. Anju, we need to wind up. If you can wind up.
I just take 5 minutes.
Yes.
It's not essential to be done. It is done in some cases to rule out other cases. And this is what this says. Then differential diagnosis, we have already discussed that we have to differentiate between UTI, medication, endometriosis, bladder carcinoma, and overactive bladder. And this is how we can differentiate. Coming to the management, it is a multi-modal therapy approach. 10 ml should be the goal. Start with conservative. Then, depending on the symptom severity and judgment, ineffective treatment should be stopped. And when we come to the guidelines, all the guidelines say that start always from first line treatment and then shift to sixth line treatment. Do not jump to the sixth line without going. Similarly, Japan Urologic Association also talks of conservative treatments first. Coming to conservative treatments, there are 3 things. We have to educate the patient. We have to tell them about the behavioral modifications, time voiding, control fluid intake, stress reduction, avoidance of stricture. And the most important is, it is said that this is because of the acidic foods, spicy coffee, tea, and artificial sweeteners. Avoid 4Cs so that there is not much of problem. Then physical therapy is the third part of first line treatment, wherein it should be done with possibly biofeedback system, wherein we can release the myofascial trigger points and give to the remove the spasm in the muscles present. Now this is the same thing which has been said, and it gives marked improvement. So when we talk of multimodal therapy, we have to see that epithelial damage can be repaired by pentosin sulfate, which is very good salt. Then when it comes to active C fibers, we do tricyclic therapies, and active help in mast cell activation of the drugs. And these are the few drugs most commonly used: amitriptyline, cimetidine, and then pentosan polysulfate. I just said it is the best drug to be used, but it has some side effects, but it has good results also. It is the orally available drug which has heparin-like function. If this does not respond, then intravesical treatment is very important, which has anti-inflammatory, analgesic, and muscle relaxant, and it improves the gag layer. It can be given as 6 treatments in 6 months' time, and it really helps. But this is how we do a cystoscopy, low pressure hydrodistension. This is the third line treatment. Inflate the bladder with low pressure on 80 centimeter with 800 to 1000 ml of urine. Maintain the pressure and then drain slowly. It can be done. The effect lasts for 6 months. And then fourth line of treatment, which is not very common in our country, is very, very common in the Western world, is neurostimulation, wherein we use bilateral S3 nerve stimulator or TENS to relieve the pain. But in India, we don't have much of the studies done. And then fifth line treatment is immunosuppression by cyclosporine A. It is very good. It is very effective, 85%, but it has lots and lots of side effects. Then the role of intraducer detox is also very good, but it requires intermittent catheterization, and up to 4 injections can be given separated at 6 months. It is not effective in patients with Hunner's lesions. Then 6th line treatment, which is to be taken at the last and not to be taken at all, is doing surgery. You can do a cystoplasty, remove the bladder completely, may add gut into it and do diversion, and but it is found that in some cases even this is not very effective. So coming to treatment part, I have already discussed how we go about it: oral, behavioral therapy, intravesical, complication, and electrical stimulation. So in conclusion, we all know that its etiology is still unknown. It impairs the quality of life in a big manner. There is significant economic burden, and there are poor treatment options because understanding the challenging facing. We have to be understand patient's challenging problem, reassure her and give her a self support care. And future research is that PBS is often undiagnosed problem impairing quality. We have to conduct lots of epidemiological researches, clinical trials, investigate the cause and development of IC and comorbid condition like vulvodynia, IBS and fibromyalgia, develop a simple non-invasive diagnostic test, develop a new uniform diagnostic criteria, and encourage standardization of biopsy techniques and resolve the nomenclature. Thank you.
Thank you, Dr. Anju. That was very, very comprehensive for a topic which we do not understand much. Painful bladder syndrome is not very much discussed. And thank you for an excellent discourse on that. The idea was to bring the audience in for a short period of time before we go to the next speakers. Because we are already running late, we'll just have 5 minutes of interaction with the audience. Dr. Shobana, I request you to unmute your mic, please. So the questions will be directed to the first two speakers, and I'll just try to have ask for very, very brief answers, please, so that we will be able to move on. So we just promised to do it for 4 to 5 minutes, and then we move on to our next two speakers for the evening. So there's a lot of questions on estrogen cream. Dr. Shobana, if I start with you. Dr. Elizabeth Joseph has asked on the dosage of estrogen cream, and Dr. Prabhavati has asked for a 70-year-old lady who's had a surgical menopause at the age of 50, what dose and how long of estrogen cream would you prescribe? So there has been a question on estrogen cream, the type of cream, the dosage of the cream, and how long of the cream at different age groups. Dr. Shobana, if you could just take a line on that.
I can quickly answer that, but there is a full presentation coming on that. The reason for that is why all my slides got mixed up, but I have to answer this quickly. You have to give they come in applicators, and you have to give it daily, initially for 1 or 2 weeks, then make it twice a week. You can give it almost up to 2 years. Cochrane review has shown that you can give it for 2 years. But 1 year is fair enough, and I told you what happened to my patient after 1 year. You stop it and she started bleeding from the ulcers, but normally our patients really don't take it for all that long. But studies are saying that you can use it for 1 year. No effect on the endometrium, no effect on, you don't have to take progesterone, so nothing will happen. So it's safe for 1 or 2 years.
And a periodic evaluation, if you would agree, maybe in 3 to 6 months.
And also, every case has to be individualized.
Individualized. Dr. Anju, you're right. Every case has to individualize. The other question, Dr. Anju, will bring you in. This is about persistent or recurrent UTI after 50 years. Dr. Satjit has asked you, persistent or recurrent UTI after the age of 50, how would you manage? Dr. Anju, if you'd be very brief with some take-home message.
It's one of the very common problems, and we need to do a proper culture. And if look for the local vulvovaginal atrophy, because that also leads to recurrent UTI. So treat that along with giving antibiotics for a longer duration. Keep rechecking the urine, maybe initially after 2 weeks, and then 6 weeks, and then maybe 3 months and 6 months. So persistent urinary infection, I say that you have to be behind it to remove it, and also treat the vulvovaginal atrophy part. And especially in our country, when women have, hysterectomy or surgical menopause, which is very common in our country. So if those are the patients who are there, we need to, treat that part also. Yeah. But local estrogens are more than enough to treat this part. We don't need to.
Yeah, Dr. Kurvi Mehta asks about laser use in vulvovaginal atrophy.
I think we can leave that because there's a topic.
Yeah. So I'll just ask her to continue watching this webinar, and she'll get her answer to what she's asking. I think Dr. Rajendra will move on. We'll go on.
Yeah, I just wanted to thank. I just wanted to mention that it was nice that Dr. Shobana mentioned about the alternative creams that are available. Where patients are not either where estrogen creams has been used for a long time, or sometimes where they are a little worried of using estrogen creams. There are a lot of alternative creams available which may be either just moisturizers or they may be actually having phytoestrogens in a local form. So that is something which she has brought out. So thank you. Yeah.
Can I come in for a minute, just for a minute?
Yes. Yes.
I have a
Yeah.
very good experience using these alternative creams, and they definitely have patients. And it
Yes.
definitely brings lots of confidence in the patient also. You know, they really feel good, and have had a lot of personal experience. So I feel they
Yeah.
should always be tried in all patients. Maybe in acute stage, we can start with estrogens, but later we can shift to these alternate, and this makes the patient feel very comfortable.
Absolutely. They need not be used just for, say, dyspareunia, where they used only during coitus, but even otherwise for the dry vagina, where it acts as a moisturizer.
Day-to-day life, yeah.
Yes, day-to-day life, right. Yes, thank you. Yes, Basab, we can move forward.
Yes.
I will come back after. I'll just log out and come back in, okay?
Sure. We'll have more questions for you, Dr. Shobana. So please.
I will come back with my mobile. I'll come back with my mobile.
Okay.
After this, so there'll be more questions. Yeah.
Okay.
Yeah, I'll come back with my mobile. I'll just check out from my laptop. I'll come back with my mobile.
Sure.
Okay, madam. Okay.
Move on to the next talk. Yeah. So our next speaker is Dr. Piki Saxena. Dr. Piki Saxena is a professor of obstetrics and gynecology from the Lady Hardinge Medical College of Delhi. She has been awarded the Corion Award, first runner-up in 2020, CS Dawn Award twice, and received 28 gold medals for research paper public presentations in national and international conferences. She's got the first prize in Best Paper published in a Foxy journal in 2017, editor-in-chief of a book on clinical guide for management of diabetes in pregnancy, Foxy publication in 2017, and postpartum hemorrhage in 2019. She's the General Secretary of the Board of Management of Delhi Diabetic Forum from 2006 to 2019. She's a member of the Drug Controller General of India's Subject Expert Committee, Reproductive and Urology Units, member of the Safe Motherhood, Multidisciplinary and Infertility Committee of AOGD, Foxy Midlife Management Committee, and Endometriosis from IFS. She's an executive editor of Indian Journal of Medical Specialties, editor of DDF Journal newsletter, co-editor of AOGD Bulletin. And Dr. Piki, we need to see more of you at Foxy forums, and we need to see more of you in Foxy around. So Dr. Piki Saxena, it's your forum, and the topic which you are going to take is vulvovaginal atrophy, is that?
Yep. And bacterial vaginosis.
Yes, vulvovaginitis and chronic bacterial vaginosis. Dr. Piki, the stage is yours.
Thank you, Dr. Vasa, for the kind introduction. I hope you can all see my slide.
Yes, we can see it. You can go.
Yes, we can see.
Without wasting any time, I'll come to the topic straight. This is a very important topic, and I think all the questions were pertaining to this. So there are a number of terms which are used to describe vulvovaginal atrophy. The other terms which are used are vulvovaginal atrophy, atrophic vaginitis, urogenital atrophy, and urogenital syndrome. Recently, the new terminology is genitourinary syndrome of menopause, which includes the full spectrum of genital, urinary, and sexual signs and symptoms associated with menopause. So what is the prevalence of vulvovaginal atrophy or genitourinary syndrome of menopause? It is about 4% before menopause, but after menopause, in the late menopause, that is about 8 to 10 years after starting of menopause, it is about 47%. And amongst the breast cancer survivors, because they undergo surgery, they are exposed to chemotherapeutic agents, and also they receive tamoxifen, raloxifene type of hormonal treatment. They are more prone to develop these vulvovaginitis very frequently. So what happens is that in premenopausal group, the vulvovaginitis in the breast cancer survivors is about 23.4%, while in postmenopausal group, it is about 61.5%. So let us come to the case scenario. There was a 61-year-old successful professional happily married with 2 grown-up children. She had menopause about 9 years back, and she approaches you in the OPD. She says that I have a feeling of dryness, itching, and vaginal pain in the private parts, and I just don't want to have sex anymore. And if we go down there, it hurts. So, what comes to your mind? This is a case of genitourinary syndrome of menopause. The impact of estrogen deficient endocrinopathy varies with the duration of menopause. In the early symptoms, the woman may experience hot flushes, insomnia, irritability, and mood disturbances. This starts in the perimenopausal age group itself. In the late menopause, she presents with vulvovaginal atrophy, sexual dysfunction, stress urinary incontinence, and later on she may develop osteoporosis, cardiovascular disease, dementia, Alzheimer's disease, and cancer. So, the estrogen deficient endocrinopathy acts through the estrogen receptors which are present in the whole urogenital area, including the vagina, vulva, labia, urethra, and the bladder trigone. So we need to note here that in the before menopause, the estradiol levels vary between 10 to 800 picograms per ml, depending on the phase of the cycle. But after menopause, these levels fall down to less than 30 picograms per ml. Another thing we need to notice, there are three types of estrogens which are present in a woman's body. Out of this, the E1 estrone is the least potent. Most potent one is estradiol, which is 80 times more potent than estriol, which is E3. So before menopause, the most predominant type of estrogen is the estradiol, while after menopause, the least potent one, the estrone, is present. So there are two problems. One, the estrogen level is going down, and the second one is the quality of estrogen is also deteriorating. So the mechanism of vulvovaginal atrophy is because of decreased estrogen, there is thinning of the epithelial cells. This leads to less exfoliation of vaginal cells, which form less glycogen production. And this glycogen is then broken down into glucose by glycolysis. So less of glucose is produced, less lactic acid is produced by action of lactobacilli on glucose. Therefore, the pH increases. This has two consequences. First is that the lactobacilli number decreases, and the other one is that there is overgrowth of bacteria. So postmenopausal bacterial vaginosis comes up, which includes overgrowth of bacteria involving normal commensals like group B streptococcus, staphylococcus, coliforms, Gardnerella vaginitis, and diphtheriae. The patient will present with homogeneous grayish discharge, fishy odor, minimal itching or irritation. And we can diagnose it by Amsel's criteria if one of the three criteria are present. Vaginal pH more than 4.5, presence of flu cells in vaginal fluid, milky homogeneous vaginal discharge, and release of amine or fishy odor with 10% KOH. So coming to the CDC recommended treatment regimens, we have all been giving metronidazole oral and vaginal tablets. We have been giving clindamycin vaginal cream, and the alternative therapies which have been suggested are tinidazole 2 gram orally every day for 2 days, or 1 gram once a day for 5 days, or clindamycin tablets, capsules, 300 milligram twice a day for 7 days, or we can even give clindamycin vaginal suppository. So what is chronic or recurrent bacterial vaginosis? So because you know that the estrogen deficiency is there to stay, so a woman, when she gets 3 or more episodes of bacterial vaginosis, the following regimens have been found to be effective in different clinical trials. So after completion of the standard CDC treatment, we can give metronidazole vaginal gel twice a week for 6 months. Or after, along with the standard treatment, we can give them vaginal boric acid capsule 600 milligrams every day HS for 21 days. This is again followed by metro gel, vaginal gel, twice a week for 6 months. Another thing which has been tried is oral metronidazole 2 gram along with fluconazole 150 milligram administered once every month for 1 year. And some trials I was looking on the net which showed that local lactobacilli preparations and even oral lactobacilli preparation have also shown benefit. So the symptoms of vulvovaginal atrophy, like this woman who presented to us, was initially lack of lubrication during intercourse, which progressed to pruritus, soreness, stinging pain, and dyspareunia. Vaginal spotting can also occur due to small vaginal tears because of thin epithelia. Recurrent UTIs, urgency, frequency, nocturia, or urgent incontinence. Stress incontinence is also seen in this age group, but evidence suggests that it is not directly attributable to vulvovaginal atrophy. And we can see here that the labia majora and labia minora are receding. The vaginal introitus is becoming narrow. The vaginal mucosa is pale, shiny, dry, and if inflamed, we can see small petechial hemorrhages here. The vaginal rugae become less prominent and then disappear. We have seen that these women have cervix which is flushed with vaginal wall. The vagina is shortened, it is becoming narrow, and sometimes is associated with thin, watery, yellowish vaginal discharge. So objectively, we can measure the vaginal health by using the modified vaginal health index. This has 7 parameters which are taken into account, which are pH, vaginal pH, moisture or consistency of fluid, rugosity, elasticity of the vagina, length of the vagina, thickness of the vagina, epithelial integrity, and vascularity. So overall, you grade from 1 to 3. The minimum score will be 8 and maximum is 24. So when we are doing clinical trials, we can use this objective criteria to evaluate the vaginal health before and after giving the treatment. So how can we help our patient? First of all, I think, as Madam also suggested and Dr. Nagarkutty also emphasized, we should always start with non-hormonal therapies which are quite effective. Lubricants can be used like KY jelly, xylocaine jelly, hyaluronic acid jelly, phytoestrogen jelly. Moisturizer and lubricants are a good choice. Even natural oils have been tried. So there's a difference between vaginal moisturizers and lubricants. Moisturizers can be safely used for a long term and they last for a while, but they need to be used regularly for optimal effect. Whereas vaginal lubricants act for a short while and had to be applied just before the sexual activity to reduce dyspareunia. Also, these moisturizers and gels can be water-based or silicone-based. Water-based is more common and cheaper and most widely used, whereas silicone gel is long-acting and more expensive. So, if these non-hormonal therapies fail, we have no option but to start with menopausal hormonal therapy. But we need to remember that it has very specific indications and it is generally indicated for only hot flushes, urogenital syndrome, our patient belongs to this category, surgical menopause, osteoporosis, or diminished quality of life. Contraindications we all know. If the patient is having liver disease, thromboembolism, dyslipidemia, breast cancer, endometrial cancer, unexplained vaginal bleeding, we do not start with hormonal therapy after menopause. We should always use the window of opportunity that is from menopause to 60 years because timely and early intervention will relieve menopausal symptoms. So what are the recommendations for menopausal hormonal therapy? These are the recommendations given by the North American Menopause Society, SOGC, IMS, NICE, and Cochrane Systemic Review. They all agree that vaginal estrogens are the most effective treatment for vulvar vaginal atrophy, and any type, cream, vaginal tablet, or ring, are equally effective for treating these syndromes. There is no need to add progestogens along with local estrogens because there is very little chance of developing endometrial cancer. Vaginal lubricants and moisturizers, they all say gives symptomatic improvement and can be used for dryness and dyspareunia. Vaginal estrogens may also be recommended for recurrent UTI when the patient is being given antibiotics again and again and sometimes you don't find anything. Then vaginal estrogen will improve the vaginal endometrium epithelium. And in case of dyspareunia or decreased sexual drive, intravaginal DHEA or transdermal and estrogen and testosterone therapy may prove useful for these patients. So before starting, we should take a thorough history and do a complete general physical examination and a local examination. Before starting the therapy, we should look at her hemoglobin, urine culture, blood sugar profile, lipid profile. We should have a pap smear. We should do an endometrial thickness and do a TVS. We should have a mammography report and do a DEXA scan to know the bone status. Regular follow-up is very much required, and before starting, we should counsel the patient. It should be treatment, should be clinically specific for that patient, individualized, and the risk-benefit ratio and the adverse effects and complications should be discussed with the patient. So the first follow-up is recommended at 3 months, where we need to find out whether she's relieved of the symptoms, about the compliance, and monitor the side effects. Then we call her at 6 months and subsequently at 1 year. The biochemical tests can be done yearly and 2 yearly mammography and TVS can be done. So the major problem is systematic absorption of vaginal hormone is a concern, but several studies comparing different doses and preparations of estradiol have shown that although systemic absorption occurs, it is to a very limited extent. And after giving 7 days of estrogen local therapy, the estradiol levels increase from 3 to 17 picograms for both vaginal tablets and estrogen creams. The systemic agents can be used, especially if the woman has got hot flashes. Otherwise, there is no role. And it has been seen that 10 to 20% of women may have residual vulvovaginal atrophy symptoms even after taking systemic estrogen, and they have to be advised local vaginal estrogens along with this systemic therapy. So this is a very important slide. I think most of the questions were being asked regarding this. Vaginal creams which are available in India, I have marked with the red, and vaginal creams are available as estradiol preparation and conjugated estrogen preparations. Estradiol preparation is 0.1 milligram per gram. I think you can just note if I read it out all, so it will take a long time. It has to be applied one applicator every day for 2 weeks, then twice a week, both for estradiol cream and conjugated estrogen cream. And after that, you can use it only 2 times a week. Vaginal tablets, estradiol, 25 micrograms have to be used daily for 2 weeks, followed by 2 times in a week. Creams are a little messy. They are lower in cost and flexible dosing they have, but preferred ones are vaginal tablets, which are more expensive, but they are preferred because they are less messy. Vaginal ring is another option which contains estradiol and can be put every 90 days, 3 monthly. It is costly and putting it is a problem for some patients. For women who have dyspareunia or sexual problems, intravaginal DHEAS capsule ovules can be used daily and improves dyspareunia. But the problems are that it causes some amount of vaginal discharge and may result in abnormal pap tests. Tibolon, it is available as Livilol in India, is a synthetic steroid having 2 estrogenic, 1 progesterogenic and 1 androgenic metabolite. It is used for treating the genitourinary symptom along with the vasomotor symptoms and bone loss. The dose is 2.5 milligram every day, but it has controversial effect on breast cancer, so should not be used for a very long time, and it should be used with caution in women more than 60 years because of the increased risk of stroke. There is another compound, the tissue selective estrogen complex, which pairs the conjugated estrogen along with the SERM dasidorexine acetate. This is available as Eprella in India. It improves vasomotor symptoms, quality of life, vaginal atrophy, and prevents fractures. It is safer for the breast and uterus without increasing the risk of MI, stroke, venous thromboembolism. Dose is single tablet every day for 2 to 3 years, and endometrial safety has been seen by a clinical study by giving it over 2 years. Another new option is ospemifene. This is a third generation SERM approved by FDA for use in genitourinary syndrome in 2013. It is useful for especially women who cannot tolerate local or systemic estrogens. The dose is 60 milligram per tablet, and the safety on endometrium has been studied up to 52 weeks. But unfortunately, this is not available in India. Another option is salbutamine. It is a thiamine derivative and has anti-asthenic properties. It improves mental, physical, emotional, and sexual asthenia. And the good thing is it can be given continuously. Dose is 100 to 200 milligram per day. But on the net, I could not find any clinical trials of this preparation. For women who are having sexual problems, we can give them intravaginal DHEA. It can be given daily and safety has been established for 52 weeks. It improves the female sexual functional index, improving the desire, arousal, lubrication, orgasm, satisfaction, and relieves the pain. So it is a important, useful preparation. But then I have already enumerated the problems faced with this. The other things like Dr. Nagarkutty was emphasizing, phytoestrogens and soya isoflavones are the substances which occur naturally in plants, and they are biosimilars to our body's estrogen. We have estrogen gel available in India. The other things which can be prescribed are obviously a healthy diet and good amount of exercise, at least 150 minutes per day. Regular amount of sexual activity will improve the blood flow in vagina and improve the vaginal and urinary symptoms. If we reduce smoking, smoking is supposed to increase the metabolism of estrogen and causes further estrogen deficiency. So if any woman is smoking, she should be asked to stop smoking. Finally, to conclude, genitourinary syndrome of menopause is a common and often underreported condition. It occurs in women who experience hypoestrogenic states. Systemic treatment, when prescribed for menopausal symptoms, may not be sufficient to control vulvovaginal atrophy, as I've already mentioned, and we may need to give local estrogens along with it. Local estrogens, including cream, tablets, and vaginal rings, are all equally effective. Thank you.
Thank you, Dr. Picky, for the wonderful, elaborate, and very lucid talk on this subject. You have covered everything. I think, as you said, rightly said, most of the questions have been answered by this talk. Since we are already behind time, we won't take questions right now, but we'll move on to the next topic for the day. May I have the CV of Dr. Ragini Agarwal, madam, please? Shrimon, if you could just put on the... The next speaker for the day is none other than Dr. Ragini Agarwal, madam. She is MS, FICOG, FICM, HCH. She is a fellow in clinical gynae endoscopy from UK, master's course in cosmetic gynecology. She was one of the pioneers in cosmetic gynecology and laser therapy in India. She's done her course from Europe and the American Academy of Aesthetic Medicine. She's a clinical director of the OBGYN and MAS, head of Department of Cosmetic Gynecology and Pelvic Reconstructive Surgery, Pratiksha Hospital, Gurgaon, a senior consultant at AA Derma Science Advanced Clinic for Women's Health in Gurgaon. She's most importantly currently Vice President of Foxy 2020 and a former founder member of the Gurgaon Obstetrics and Gynecology Society. founder president of the Haryana Association of Obstetrics and Gynecology. So it's over to you, Ragini madam. She has another program lined up, but then she's waiting for us to put her on so that she can start with the talk. Thank you, madam. Dr. Ragini Agarwal, for you.
I guess Dr. Ragini has dropped out. Yeah, she's connecting again.
These are technical glitches which do happen sometimes, and we have to cope up with it.
Hello, hello.
Yes.
Am I audible?
Yes, ma'am.
Yeah. I don't know what has happened suddenly. When I came on the screen, my computer is gone. Meenal, can you share my talk? I have given it to you. Hello?
Yes, doctor. Yes, doctor.
Please share. I will speak.
Please, yeah.
Yeah, I will speak. No problem. Meantime, if it comes.
It's like endoscopy, you have to put up with it.
No, it's a. I have a 27 June.
Yes.
Yeah. This is my talk. Yeah. Good evening to all of you. I will not take much time as many slides are very, very repetitive. Thank you, Dr. Nagarkatti, for giving me this opportunity. And this talk is very, very close to my heart. So, as Dr. P.K. Saxena has speaking most of my slides, initial slides, I will just skip them very quickly. Next slide, please. Meenal. So, it is very, very clear that 50% of the postmenopausal women may be affected by GSM, and many women may not report the symptom because they are embarrassed, or they are unaware, or their symptoms are related to menopause. They believe that it is a part of aging. Next slide. Next slide, Meenal, please. So something like menopause, it is the eternal truth of every woman's life. But beauty of maturity lies when these changes, they can be paused and a person has a good life. 84% of the women says that symptoms interfere with their lives, and 12% say that they interfere a great deal or debilitating. And most common symptom with these women, they have a hot flashes in 50%, but yes, 38% have a vaginal dryness also. And 42% say they have never discussed menopause with their healthcare provider, and only 1 in 5 received a referral to a menopause specialist. So to see so many women beyond 50, they are suffering silently with the problem, and they are not even aware or embarrassed to, in this era, to talk to their healthcare provider. Next slide, please. So what is genitourinary syndrome? It is basically nothing. It is an old wine in a new bottle. When we are a student, we called it with a different name as a vulvovaginal atrophy, as a senile vaginitis. Now it is a single umbrella to cover all genital symptoms, sexual symptoms, and the urinary symptoms which a menopausal woman undergoes as a genitourinary syndrome of menopause. Next slide, please. Next slide. So it is a common condition. It has a negative impact on life, and lack of awareness for treatment is the mainstay. Next slide, please. So it's a new terminology given in 2014 by the International Society for the Study of the Women's Sexual Health and the North American Menopause Society. Next slide. This genitourinary syndrome of menopause is basically a chronic progressive vulvovaginal sexual and the lower UTI condition characterized by a host of symptoms secondary to a clinical state, and 15% of the premenopausal women and 40 to 54% of the postmenopausal women suffers from it. And why we are talking about it, by 2030, more than that 17% of the population will be of the 65%. So think of the magnitude, how many women are suffering with the GSM. Next slide, please. So GSM is often undiagnosed due to the sexual embarrassment or the gender disregard. And in case of the abrupt estrogen deprivation, a surgical menopause patient can experience significant sexual dysfunction and even poorer quality of life and outcomes. Next slide, please. So in a recent study, it was found that the 4% women were able to attribute vulvovaginal symptom to GSM, and another European study found that 54% women discussed their sexual health. So this one parameter we should keep in the mind when we are taking the women of the GSM. It is not only about the urinary symptom, it is not only about the vulvovaginal symptom, it is about their sexual life, which is very, very important. And it really put a very, very great effect on their day-to-day life, their quality of life decreased like anything. Next slide, please. So, as Dr. Picky has also said in detail that the highest concentration of estrogen receptor is present everywhere in the reproductive tract, mostly in the vagina, with estrogen receptor alpha almost solely active post-menopause. Next slide, please. So, if you see in the pathophysiology, there's a loss of estrogen goes due to this. There's anatomical changes, there's a functional changes, and this lead to a physical symptom in all of the genitourinary tissues. Focus on this point, the loss of the collagen and elastin. That is the point where the laser is going to act mostly, and this action of the laser is going to convert in what? There's a reduction of the number of the blood vessels, which is going to be increased. There's an increased connective tissue. And third part in the pathophysiology is the thinning of the epithelium, that is the diminished blood flow, reduced elasticity, increased vaginal pH, increase in vaginal pH, and changes in the vaginal epithelial cells. So all these four factors is going to be taken care by the laser treatment of the GSM. Next slide, please. So next slide, it is our symptom and signs which all we know as a gynecologist. Next slide, please. So this vaginal health index 6 score is another thing which we should always remember with any postmenopausal woman is coming to us, and it is again in detail. Next slide, please. Detail. Dr. Picky has given you in detail. Next slide, please. Where she has told you about the all parameters and how we number it. Next slide, please. So coming to a few slides on the sexual dysfunction, why this laser therapy is being offered, and a part of the aesthetic gynecology and regenerative gynecology. So this vaginal discomfort has a negative effect on the sexual dysfunction. Among women with vulvovaginal symptom, 40% also reported overall sexual dysfunction, 20% lack of desire, and 34% talk about the arousal difficulties, and 19% talk about the orgasm difficulties. So nearly 4 times more likely to have a vulvovaginal symptom than those without sexual dysfunctions. Next slide. So management of a woman with sexual dysfunction requires a more complex and multidisciplinary approach. The severity of the symptoms, including loss of libido, dyspareunia due to vulvovaginal atrophy, and pelvic floor tension, will determine the therapies required. It was discussed with the previous speaker that lubricants and moisturizer may be recommended initially for the dryness, and the vaginal estrogen are prescribed when severe atrophic changes are present. There's a study of women's health across the nation in USA which reported that the women with a sexual dysfunction considered vaginal dryness to be an important associated with the menstruation, pain, arousal, physical pleasure, and the emotional satisfaction. So what we offer, before offering pelvic laser therapy directly, please never jump up laser therapy directly. We have to evaluate a patient. It has to be customized. Patient may be having other things also. So regular detailed history examination. Then we have to offer other things like pelvic floor physiotherapy, physical trainers, considering changing in the regular medication because the elderly women may have other medication also, and drift to a sexual therapy. Some cases, along with the couple, counseling may be necessary. Maybe we are only focusing on the woman and there are some other underlying causes also. Then, because of the common, next slide please, next slide, next slide, next slide, next slide please, next slide. Yes, there's a common embryonic origin, both arising from the urogenital sinus, and there might be a estrogen deficiency which lead to the lower urinary tract dysfunction also along with the sexual dysfunction. So this GSM no doubt affect the quality of life and negatively affecting the self-esteem and the intimacy with their partners. Next slide please. So there's another study on the closer study found that the vaginal discomfort had a direct negative impact on the intimacy, resulting in a loss of libido. Next slide please. So women reported that their vaginal symptom negatively affected enjoyment of the sexual activity, sleep, and overall enjoyment of the life. Next slide. As I told you, you have to go for the medical history, potential risk, benefit of the exogenous administered estrogen therapy, and the patient lifestyle. It is, next slide, it is a chronic condition and management of GSM varies according to the symptom severity. And to assess the effectiveness of the treatment, a PS test and a cytologic analysis may be utilized. Next slide, please. When we talk about the treatment of the GSM, the primary goal is that treating the GSM is to relieve the symptom. First line therapy, long-acting vaginal moisturizer with a short course of the low-dose vaginal estrogen. And for the further treatment, we go stepwise treatment is required. No doubt the estrogen, next slide, estrogen therapy is the mainstay and it is the most effective therapy, but it is not always we can give, and many time patient is not ready for the estrogen therapy always. So there's other option is available like SERMs, ospemifene, which is recently FDA approved. There's a tissue specific estrogen and laser therapy, which has been shown to improve the elasticity, vascularity, and the epithelial proliferation. Along with that, DHEA, as Dr. Piki Saxena has already told you. So coming to the laser in the GSM, next slide, please. Next slide. Yeah. So there's a two different laser technologies is available with us for the proposed treatment of the genitourinary problem. One is microablative fractional carbon dioxide laser, and second is the erbium YAG laser. And if you see this chart, you see there's a ultraviolet light, then there's a visible light, then the infrared spectrum. So this erbium YAG and the carbon dioxide laser both come in the infrared spectrum of the light. It is around 2,900 is the erbium YAG and the carbon dioxide as a 10,600. Next slide, please. So laser treatment with this carbon dioxide laser, erbium YAG laser, or a new thing in market is the hybrid laser. I haven't seen it yet. It activates, what does laser basically does? It activates heat shock proteins and tissue growth factors to stimulate new collagen genesis, new vascularization, within the vaginal epithelium. And most evidence on the laser therapy for GSM comes from the prospective case series with the small numbers and the short-term follow-up with no comparison arms. That's why the most of the regulatory bodies is still not ready to give their go-ahead for this thing. Although in recently, Ayuga has made a special interest group for the cosmetic gynecology and laser. Maybe in future they will come with the guidelines. Next slide, please. So we have two things: microablative fractional carbon dioxide laser with a wavelength of the 10,600 nanometer absorbed strongly by the water and works by creating superficial microablation zones. Now, if I talk about the superficial microablation zone, understand a small superficial burn on your skin. It is this aseptic wound on the mucosal surface. As a result, a healing response is triggered, resulting in a new collagen formation. And in the non-ablative erbium YAG laser, it has a wavelength of the 2900 nanometer and works by creating rapid sequential heat pulses which are compounded and transferred deeper into the mucosa. The fast heat pulsing results in the tightening of the mucosa and the stimulation of the new collagen formation without injuring the tissue surface. This is the two basic difference, but because of this basic difference of the superficial microablation and in result is a healing response which is triggered, it is found that in GSM cases, microablative fractional carbon dioxide laser is more effective for the new collagen formation. Next slide, please. Now there's a recent trial where what we are waiting for a comparing a vaginal laser with a vaginal estrogen alone or with a combination laser plus estrogen arm. A first series has come. Next slide, please. In this single site randomized double conducted in brown and carbon laser plus estriol green. Next slide, please. Next slide. Yes. Yeah, please stay on this slide. So the primary outcome was that a change in the visual analog scale score for symptom related to vulvovaginal atrophy, including perineal dryness, burning was taken, and change in the objective VHI was. So next slide, please. Next slide. Secondary outcome included desire around lubrication, orgasm, satisfaction, and pain. This period, next slide, please. So what it is found that the microablative fractional carbon dioxide laser therapy for management of GSM achieved a statistically significant improvement in all GSM symptoms, including the 10 centimeter visual analog scale, according to this study. And this study data were from two previously published prospective observational trial assessing the efficacy of carbon dioxide laser therapy in postmenopausal women with moderate to severe GSM symptom. Next slide, please. Yes, we should always remember this FDA warning, and remember this FDA has approved this laser for conization, for cautery in the vagina, for other operation on the cervix, on the vagina, but only this word was not used at vulvovaginal rejuvenation, where we give the laser for a very, very short time and only 4 millimeter depth laser has gone. So I will, next slide please. I quickly show you some abstracts which was in PubMed. There's a vaginal rejuvenation using energy-based devices. Next slide. There's a laser for the pelvic floor dysfunction. Is there evidence? Next slide. There's a laser therapy as a treatment modality for the GSM, a critical appraisal of the evidence. Next slide. So this laser is, next slide, is well tolerated and may increase the thickness of the squamous epithelium and improve vascularity of the vagina. These morphological changes presumably elevate symptoms of the dryness, dyspareunia, and irritation. Next slide, please. This is the machine which we use, and it is a robotic arm. In this robotic arm, the setting, we have to set only how much joule power we have to give. Rest, everything is computerized. We have to put this probe inside the vagina and start the machine just to push a button, and it rotates 360 degree and come out of the vagina. And this effect of the laser, when it goes inside the epithelium, it absorbed by the water act as a chromophore for the laser, and it heat up to the 45 to 47 degrees centigrade and denature the collagen. Next slide, please. The added advantage of the using EBD, that is the energy-based devices, is in post-cancer treated patient following radiotherapy or for breast cancer survivors where hormone therapy is contraindicated. Next slide, please. So what happened is in non-invasive procedure, there's a decreased estrogen production during the perimenopausal period, reduces the fibroblast activity causing the dermis atrophy, we all know. And with age, human skin visibly lacks, losing in the previous volume and shape. And thirdly, the loss of firmness in the water may promote injuries or infection. Next slide, please. So this vulvovaginal dryness is a common complaint reported by the perimenopausal women, especially those who do not use HRT. And this labial atrophy due to the loss of the subcutaneous adipose tissue leads to the more opening or relaxation of the vaginal introitus, open the vaginal canal and more exposed to the dryness. Next slide, please. So the meeting diverse medical challenges with one solution, energy-based devices, either fractional carbon dioxide laser or RF or erbium YAG laser, is a complete solution that treats a wide range of feminine indication. Maybe it is vaginal tightening, SUI, vaginal dryness, postmenopausal GSM, or post-delivery rehabilitation. Next slide, please. Laser has been safely used on the skin of the face, neck, and chest to produce new collagen and elastin fibers with remodeling of the tissue. From our dermatological colleague, we have taken a step towards our gynae uses. And in September 2014, FDA cleared the use of the carbon dioxide laser system for incision, excision, vaporization, and coagulation of the body soft tissues in the medical specialty that includes gynecology and the genitourinary surgery. Next slide, please. Fractional carbon dioxide laser technology involves emitting beam of light that creates a pattern of the small ablative wounds without damaging the surrounding tissue, which aims to stimulate tissue regeneration. And this energy is delivered to the target tissue through a specially designed scanner. This laser with its scanner provide high precision and char-free tissue ablation with well-controlled layer by layer laser vaporization, enabling minimal damage to the surrounding tissue. As I told you, it is a 4 millimeter depth the laser beams goes. Next slide, please. So if you see in this diagram, there's a one beam is coming and it is dividing in a micro beams. This is called the pixel effect. There's a 9 into 9 millimeter spot size beams, and it goes inside, and there's a thermal effect is achieved in microscopic columns surrounded by the spared tissues from which healthy cells are recruited to accelerate the healing process. Next slide, please. So what is the advantage when we use this laser? It is minimally invasive, virtually painless procedure, gentle treatment for the control, safety and accuracy, maximum precision with carbon dioxide laser, the right wavelength and the perfect pulse. It is fast, efficient delivery of the fractionated laser energy split into the micropixels. That is the most important thing, how it is different from the ablative laser to the microablative laser. And no post-treatment, that's why there's no post-treatment downtime, and there's an excellent patient satisfaction and the long-term success. Next slide. So if you see, How this laser effect? There's a laser goes inside, amount of the energy reflected, some is absorbed inside and scattered in the tissue, but a very small amount will transmit and taken by the chromophore. Here, chromophore is water in vagina and it is absorbed. Next slide, please. Next slide. So what happened when this energy goes inside the cell? It deliver to the tissue via probe and the surface of the skin, and it activates the mitochondria, and it activates the ATP, ROS, and NO, which leads to the cells changes. So in the end, there's a photostimulation, photodynamic reaction, and photothermolytic action. Next slide, please. So this Plexel carbon dioxide laser is a strong and impactful thermal effect. It is a high-powered laser, utilization of much higher energy levels by longer pulse duration and microscopic columns of the thermal zones. Next slide, please. It leads to a thermal damage. Next slide. Yes, superficial shrinkage and the deep aseptic wound, and leading to the collagen remodeling. Next slide. Next slide. Next slide. Yes. So what happened when we do the treatment? The phase 1 is within 40 to 72 hours. There's an early thermal effect leads to edema, release of the chemical mediators, and the shrinkage of the collagen and the elastic fibers. Phase 2 is the following 30 days. There's a proliferation. There's a fibroblastic recruiting. If you remember my previous slide where I told you we all know that there's a postmenopausal, there's a decrease in the fibroblast. So here the fibroblastic recruiting, new extracellular matrix, and new collagen fibers of the type 1 and type 2. In the elderly female, it is a type 5 collagen fiber, which is easily breakable. It doesn't give a strength. And this new collagen fibers, which forms after the laser treatment, is a type 1 and the type 2, which gives a good strength to the extracellular matrix of the vagina. So phase 3, after 30 to 40 days, there's a remodeling, mature collagen fibers, increase of the collagen fibers. There's a new vascularization. More of the new blood vessels leads to the good cells, more of the superficial cells, improved lubrication. There's a more of the glycogen production. Lactobacillus colony is improved and leading to the pH, decreased pH, that is the acidic pH. So there's a physiological and the functional recovery of the vagina mucosa occurs. Next, please. If you see this diagram, please put 2 times. Yeah. Again, one. Just click it once, click it twice more. Please click it twice more. Yes, one more. Yeah, if you see this diagram, the first diagram is a young woman who is stratified, and second there's a jumbled up, it is for a postmenopausal woman, and third slide like a younger woman after the laser treatment. Again there's an increase in the superficial layer, increase in the new collagen, and there's a development of the dermis layer. So this carbon dioxide laser removes the abnormal upper tissue layers and stimulates new collagen growth in the dermis to effectively restructure and restore it. Next slide, please. Not only that, we can use it for the SUI and the urge incontinence of the elderly also. Next slide, please. Next slide. Next slide. Next slide. There are some other few literatures. So coming to the next slide, please. Next slide. Yeah. It is very, very important. Always this, if you go for any new thing, the medical legal considerations are very important. You have to do a good counseling of your patient, and fully informed consent is fundamental like any other procedure. And clinician who perform vaginal laser must be aware they are operating without a clear evidence basis for any regulatory bodies. Women should be advised accordingly, and owing to the anatomical development, it is not for GSM, for other things, never offer to anyone below 18 years of the age. Next slide. Like any other medical therapy, we have a contraindication. Never use it if patient is having an active vaginal infection without pap smear, any doubt of the cancer, undiagnosed vaginal bleeding, uncontrolled diabetes, or any vaginal injury. Next slide, please. Treatment protocol, it is an office procedure, no anesthesia, 2 to 3 passes for entire vaginal canal, 3 session, 1 month interval, 1 mammary session after a year, and may repeat full course after 2 years. But in the GSM, many time we have to give after 1.5 years only, because patient does not have their own hormones at all. And the second thing which I want to say, when we are taking the older women, we always start with a very, very low energy, because their epithelium is very thin, very past. It's lack of the, there's a lots of lack of the water, it's dry. So taking the GSM patient, always see how is the mucosa, and very low energy start and see how the mucosa is responding, and only then you can increase your energy level. Next slide, please. Next slide. Next slide. Next slide. Next slide, please. Come to conclusion. Yeah. Just to conclude, I can say this genitourinary syndrome of menopause is the latest terminology instated to increase awareness and reduce social stigma of the genitourinary sequelae and sexual dysfunction associated with the postmenopausal hypoestrogenism. Next slide, please. And this laser therapy is a recent method for the treatment of the symptomatic vulvar and vaginal atrophy. It is introduced extensively to healthcare practitioner and directly to consumer. So further research is needed in the form of controlled studies of the laser and other non-hormonal GSM therapies, and controlled studies with a long-term follow-up are needed. Next slide, please. I thank you each and everyone from where I have taken the articles from the net, photographs, and I will finish my talk with this slide. The man who will neither play nor do business unless everything is just to his liking and notions retards rather than contribute to the progress. Thank you very much for this late talk. Thank you, everyone.
Thank you, Dr. Ragini. Thank you. That was very, very innovative. We hardly hear about lasers in vulvovaginal atrophy and GSM, as you rightly put it. It was a very nice talk. May I ask all the speakers to unmute themselves? Dr. Piki has not unmuted. Dr. Shobana, if you can unmute. Dr. Rajendra, with your permission, can I take a few questions?
Yes,
so we are
yes, please. Please continue.
Dr. Piki, I'll bring you in the picture. There are some questions for you. There's Dr. Deepti Nab has asked, where do we get vaginal boric acid? And what about metronidazole vaginal creams? Are they available in India? If you'd like to take that, please.
Vaginal boric acid is not available in India, and the other question was, it is not available in India. The boric acid is not available.
Metronidazole vaginal cream.
Metronidazole vaginal cream, there is a preparation available. I don't know whether it is available in India and by which name.
Fine. There's another question, Dr. Piki, for you.
There is a tablet, I think.
No, it is available with the name of...
There is one. Dr. Anju, if you want to come in.
There's a tablet of metronidazole.
It's available by the company, and initially it used to come with the applicator, but now for some years they have started supplying the applicator. But it is there available, and on some patient it's quite effective.
So it is available, but may not be that freely. Dr. Piki, I'll ask you another question. This is coming from Dr. Jyoti Shah from Rajkot, and the question is, have you heard about a condition of lactobacillus overgrowth, which appears in a pap smear as something called cytolitis vaginosis? Have you heard something like that? Is it something, would you comment on that? Lactobacillus overgrowth in a postmenopausal woman, where a pap smear report of cytolitis vaginosis. Would you have heard something?
We haven't heard of such things. It's new for us.
I think that's Dr. Anju, there's a question from Dr. Savita on cystoscopy features of painful bladder syndrome. Would you like to highlight them? You spoke something on glomerulation. They wanted to have some more idea of cystoscopy features.
Yeah, when you do a cystoscopy, you have, maybe vessels diverging from one point, like, this thing, from going from one point to all other points around, all around. That is one feature. The other feature is that you may have, rainfall like of hemorrhages when you fill the bladder and empty it and then again refill it. Sometimes you find ulcerations also in the bladder, but you should look for all the quadrant of bladder, fundus, up, left, right, and down. And then there should be multiple areas as advised in the guidelines, and then take biopsies from those areas.
One more question for you, Dr. Anju. How do you evaluate rectal or pelvic floor muscle tone? This is coming from Dr. Archana Kashyap. She's asking, how do you evaluate rectal or pelvic floor muscle tone?
The best thing is that you put your fingers in the vagina and tell the patient to contract. So you will feel the pressure in your hand, and that's the best way. And also when you, put some kind of, say, maybe, blunt instrument, like we use that hammer handle around the rectum, the anal. There is an anal sphincter that is known as anal reflex. So that shows also the anal tone, and this is checked especially in cases of overactive bladder syndrome.
Dr.
And one more thing I want to say, that in most of the cases of overactive bladder syndrome, we do not tell them to do this Kegel exercise, because sometimes Kegel exercises increase the problem. So we tell them not to do Kegel exercise, rather stop them for a while, do other exercises, and we need to feel. There are sometimes those tender spots, maybe or at the episiotomy site, or some tears, those areas. So feel them. And I had one patient who had this spasm of small muscles which comes from the pelvis, and that muscle spasm was giving her the problem. So we gave her a little massage, right, with this jelly, and it really helped them.
Yeah. Can I comment one thing? Basant, can I comment one thing?
Dr. Ragini, please.
Yeah, so there's something called biofeedback. If this patient comes to us, and especially as Dr. Soni has very rightly said, we don't
Dr. Ragini, we can't hear you.
Yeah, Suma, most of the things
Dr. Ragini, we lost you somewhere.
Rightly pointed out by Dr. Ragini, in all the foreign countries, we have very few centers, maybe in India, who look into this. There are few urogynecologists who are doing this, like Dr. Aparna, all those people. But biofeedback should be done, but it is not available easily in our country. Of course, it's very well available abroad, where they do biofeedback, and that is very, very helpful. Biofeedback is the therapy which is required to be done in painful bladder, and we need to find out which are, some patients I found out that the pyriformis muscle is the one which, when it goes into the spasm, gives the problem. So we need to find out which muscles is involved, or which scar tissue is giving the problem, because patient may come with a history of some kind of instrument, maybe delivery, maybe bladder instrumentation, where there's a possibility of scars in that area. Those are the patients who will have this problem of painful bladder syndrome. They are more prone. These are basically high risk factors.
Thank you, Dr. Anju. I think we'll move on. We've got a lot of questions. We need a very short and brief answers. Dr. Shobana, I want to bring you here. 50 plus women with bedwetting issues. Could that be a neurological problem? This is asked by Dr. Manjula.
I'm sorry, Dr. Basab, I did not get it correctly.
So we're talking about 50 plus women with bedwetting issues. Bedwetting.
Bedwetting, okay, bedwetting, yeah.
Immediate postmenopausal.
This is where you have to clearly make out the difference between urgency, overflow, and stress incontinence. You know, we think bedwetting is because of an extreme degree of stress urinary incontinence, and they can be cured by just putting a tape in. But you have to really make out if it is stress incontinence. The second thing that could be a mild little form of urgency incontinence can also, they just minute they decide to go to the toilet or even for running for a marathon or something like that, they start, you know, one little drop comes into the panties and they have to constantly have it. Bedwetting by itself could be overflow incontinence like the person whom I told you, if it is not urgency or stress. So you have to take an ultrasound, see how big the bladder is, and if is the amount of urine inside the bladder is very high, then you have to think in terms of overflow incontinence or your good old nocturia. You know, you have to give them something to nocturnal enuresis that we have in small children that can also happen 50 plus. In my practice, whatever I have seen, it is mostly because of overflow incontinence. That's what I can.
Dr. Ragini, these are the next few questions.
Okay, hello. Am I audible?
Yeah.
Okay.
So the next few questions are for you. This is about how long does laser take to improve PSM?
Hello.
How long does laser improve PSM? How are there any side effects? How long does the effects of laser last? And how much cost? So a lot of questions.
How much it loss? There are three things. Number one, there's a set protocol. We have to give a memory section for these all women nearly 8 to 12 months. And after that, it all depends how much patient's own body react, because reaction of the laser to the collagen of the woman is still, it is not measurable. It is your body how to it is react. So some women need another session after 1.5 years of the memory session. Somebody require only after a year. Some require after 2 years. We have this machine for last 2 years, and most of us in India, the group of doctors having this machine for between 2 to 3 years, and 50 and half of the full treatment. So there's one question there's always asked, क्या ये हमारे को हमेशा के लिए नहीं ठीक कर देगा? Hello?
Yeah,
we can hear you, madam.
Hello?
It's not very strong, but we can hear you, Dr.
This is a most common question which is being asked to us. क्या ये हमेशा के लिए नहीं ठीक कर देगा? बारी बारी.
No, we are not audible. She's not audible now.
She's muted. Dr. Ragini is muted.
You have muted yourself.
Yeah. So simple answer which we gave, especially it is very easy to go that way, कि आप पार्लर में बार बार फेशियल कराने जाते हो ना, सो दिस इज समथिंग विच वी कांट से कि ये एक बार करा लिया तो लाइफ के लिए हो जाएगा. आपका जो डे टू डे डिजेनरेशन हो रहा है वो तो चल ही रहा है, तो उसको पेपअप कराने के लिए इट इज योर बॉडी, यू मे रिक्वायर अ ट्रीटमेंट अगेन एंड अगेन.
Okay.
Cost of therapy, I think somebody asked.
Cost of therapy is very, very on the person.
Yeah.
Whatever you want to take, it is totally up to you. Machine costs 50 lakh rupees and 10,000 is the consumable. That is a fixed thing. You want to charge this total. Somebody charges 5,000 per session. There are people who are charging 25,000 rupees per session. It is totally up to you what you want.
Sure. So a couple of questions to Dr. Piki. Dr. Piki, there's a question about vaginal moisturizers. Dr. Smith asks name some vaginal moisturizers, and there's also a question on do we have enough of studies on isoflavone gels? This is from Dr. Kaushal.
Which gel?
Juventus has got that, no?
Isoflavone gel.
Isoflavone gel. Aventis has got one iris gel which can be used. This is a phytoestrogen soy isoflavone gel, which is quite effective. And the other gels generally which are being used are hyaluronic acid, lidocaine gel, xylocaine gel, and KY jelly also. But they are lubricants, not moisturizers.
Juventus,
the hyaluronic gel of
Juventus
Juventus is a moisturizing hyaluronic gel called pelvic gel. That will just cause
they also have phytoestrogen gel by the name of Iserin.
Yeah.
Iserin gel.
I had shown that in my slide also.
Yeah. There's a question for Dr. Ragini Madam. Difference between laser and RF effect by Dr. Savita.
So it is very clearly most of the article which are present on the net that as far as genitourinary syndrome of menopause is concerned, carbon dioxide laser is much effective than the RF. We are not talking about other indication of the lasers for the cosmetic purpose, but if we talk about the GSM, the carbon dioxide laser is the considered best.
Okay.
That answers most of the questions. Dr. Rajendra, if you agree, I think we will
I think
take a call
for an excellent session. Thank you very much. And if you have some take-home messages before we wind up, one message from each of you. Dr. Shobana, one message from the audience.
But I had already said that when you talk of continence, you should not think only of putting in tapes. Urgency is curable, even if it's your mother. They'll say, I'm old, why do you have urgency treated? My mother also doesn't take medicines, but it is very good to take medicines and be on the go rather than not take medicines. And you have to think of overflowing incontinence, and you have to see what medicines the person is taking. When you're called for a consultation in an ICU, and in a neurology patient or a psychiatric patient or any other patient, look at all the medications. And then you start putting them on your anti-urgency drugs.
Very nice, madam. Thank you.
Because many drugs have got effect on it.
Dr. Anju, some take-home message for the audience.
Thank you so much. Thank you for calling me.
I would like to say that painful bladder syndrome is not that uncommon as it is known to be. And it is, if a patient comes to you, please do not refer the patient to urologist. Because most of the first, second, and third line of treatment you can give yourself. Take a proper history, properly investigate and see. I think you will be able to treat most of them yourself, and your patient will not be shuttling from one place to another and be unsatisfied. And
in fact, I would like to add here that there is a association called GIBS, Global Bladder Interstititis Society, and they are mainly urologists, and they themselves feel that this particular problem should be made aware to the gynecologist, because patients come to us more often in the beginning, and we have to, like you rightly said, the first 3 or 4 lines of treatment are in our hands. So we should be aware of this problem, and that is why we particularly included this topic. And thank you for bringing this out, Anju madam.
You have to be very, very supportive, very, very human to the patient. That giving your confidence from your side is most important, and patient, you will really like them. Be human, be nice, and be supportive to the patient.
Thank you. Dr. Piki, some take-home messages from your end.
Yeah, I think any woman who is coming after 45 years of age, we should talk about genital urinary problems, vaginal problems, because it's a very common but underreported and neglected problem. So we should ask them, and we should be very respectful and empathetic to the patient, take a good history examination and discuss all the risks and benefits, and start the treatment as soon as possible.
Dr. Ragini, you have the last word. Dr. Ragini, lasers, we can't hear from you. You have frozen. Yes, Dr. Raju. Yes, Dr. Raju.
So, yeah.
We can hear
So
you.
my one-line message will be the menopause doesn't pause your life. This message should be make aware to each and every woman. This is your second life, which you have all right to live fullest. So we should take, as an association of the women, we should take this thing in stride. We take every opportunity to teach our every woman coming to us after 40 that these are the treatments are available for these problems, and we should not call them as a patient, because they are not patient. These are not diseases. They are the part of the physiological part of their life, and which can be taken care. And there's something called like menopausal care, like antenatal care.
Thank you. Thank you very much.
Thank you.
Dr. Rajendra Nagarkatti, Chairperson of FOGSI Midlife Management Committee. Thank you for involving all the panelists and myself. Wish you many more successful programs in the days to come.
Thank you from our
Dr.
side also.
Basab.
Thank you,
so
Dr.
much.
Basab and Dr. Nagarkatti.
Thank
Thank
you,
you, Dr.
everyone.
Nagarkatti, for inviting me for this.
And thank you all delegates for joining so late. Thank you. Thank you very much.
Thank you, Juventus, for
Bye-bye.
Thank you for being on for so late, and we will meet again. Thank you.
Thank you.
Thank you,
Thank you so
Basab,
much.
for
Thank you.
Basab, for wonderfully moderating. Thank you.
Thank you.
Thank you, everybody.